Good afternoon, everybody. This is the July the 2nd, the day before the long weekend starts here in the US, edition of THCB Gang. And we have a small and mighty gang this week, but it's going to be really great fun. And sadly, it's a mantle. We're trying, I don't encourage that around here, but it's a bit like my high school and college years. All the women turned me down. Anyway, so today on the lineup, it's going to be real fun. We have some regulars, Rajesh Aggarwal, who went from being a guest to being a regular, who's at the EVP of Strategy at Jefferson in Philadelphia, and a very busy guy doing bariatric surgery. We'll talk about that. Michael Millenson, old friend, quality and patient safety expert from Health Quality Advisors. Dan O'Neill, who I've been hunting to get back on the gang since he was here a few weeks ago, who's a Robert Johnson Fellow, done a lot of work in startups, and has a very, very keen eye on the finances of hospitals. And our special guest this week, Marcus Whitney, does a lot of stuff, but is the CEO of Health Further in Nashville. Sorry, not national. It is national, but it's in Nashville, and part owner of the Nashville Major League Soccer team, which started playing this season and then stopped almost immediately because of COVID, and has a new book out. We'll talk more about that in a second, but here's the gang, and let's go. All right, welcome everybody. Glad to see you all. Dan, you like you're in Hawaii enjoying yourself. Travel is back up. Everyone else is so let's just start real quick, go around the horn, and have a quick follow-up to what we've seen this week, because I keep on saying this, but it's been a hell of a week again. All right, Michael, what did you notice this week? Unmute yourself. Actually, let's go to Raj while Michael's unmuting himself. Raj, what do you notice this week?
Cool. So the acquisition of InTouch Health by Teladoc was completed yesterday. Just in full disclosure, through Strategic Ventures at Jefferson, we have a strategic partnership with InTouch Health and also with Teladoc separately. But yeah, I mean, just at a general level, I was looking back to when it was announced on January 12th, when I was at JP Morgan. The Teladoc stock price was $70 or thereabouts. 2 days ago, it was $190, and today it's $210 with a market cap of $15 billion. Very, very impressive. Is it real?
We can discuss multiples with our venture capitalist on it, multiples for SaaS businesses in healthcare. I mean, could be crazier. It could be a car company worth $200 billion that has never made a profit. We'll discuss that later. And you don't even get the rocket company with it. All right. Michael, back to you. What do you notice in the last week?
Wait a second, Raj, if you guys own a piece of Teladoc at less than 19 and now it's 200, what are you doing here?
We don't own equity. It's a
they don't know
deal.
Right way.
Yeah.
Michael.
I think to me, the most interesting event of the week was Liz Cheney tweeting under the hashtag "Real Men Wear Masks." And so now you're starting to have basically Mitch McConnell, Liz Cheney, and people like that saying, hey, even if you love Donald Trump, you got to take this seriously. And so I think that's kind of a turning point in perhaps depoliticizing the pandemic, which should never have been politicized in the first place, and having the country realize that we have to take this seriously as a nation, not as a red state, blue state agglomeration.
We'll see about that. All right, Marcus, before I won't introduce you a bit more properly in a minute, but for now, just your quick take on the week or a couple of weeks events.
Yeah, so in Nashville, we've sort of got two storylines going. I would say on the healthcare side, much of the chatter is around the courts upholding the Trump transparency order and what that's going to mean and how all of the systems are going to respond to that. It happened a little over a week ago, but it's a big enough deal that everybody here is talking a lot about it. And then the other thing that we're talking about here is over the weekend, Nashville, not the city proper, but the region made national news because a country music artist named Chase Rice decided to throw a concert and had 1,000 people there. And it was all over the internet, and he actually shared it himself. And, when you see the people, they're just all on top of each other. It looks like nothing is happening, right? It looks like we're back open. Everything is fine. And just how impossible it seems for us to get on the same page about how to respond in the middle of this public health crisis.
We'll talk about that for sure. Dan.
I've been paying attention to a couple things in addition to the COVID news, as always, of course. On the health tech side, I think there's the Accolade IPO, which is interesting. That's something I've been watching for the last couple of months, and the huge fundraising numbers for the first half of the year that we saw from Startup Health. I think that is just interesting in a bunch of ways, given what's going on. And then on the sort of kind of enterprise healthcare side, I guess you might say, watching the sort of bounce back that we've seen, at least so far, in hospital visit volumes and in some of the reports from some of the for-profit chains, and the job numbers today that show a continued bounce back for both physician practices, in particular dentists that have come way back from those extreme depths, and then to a lesser extent hospitals.
Yeah, no, amazing stuff on that. And actually, I have two things to note for the last week. One, I'm going to have the tweet that I've been spending a lot of time nudging my friends in the big hospital systems, but this one is the tweet that you put out, which was the collection jar to help Partners Healthcare, which was in some gas station that was good. And there was one, I thought that there was a local brewer, like a microbrewer, that was selling beer to fund Innova. You know, and I was going, these are places that the last time I looked, Partners had more than $1 billion just in the Cayman Islands alone, you know. There we go. But on a more serious note, where I sit, I live in Marin County, which has been, you know, very lightly affected just north of San Francisco until the last couple of weeks by COVID, when the thing that's in Marin County you may not know about is San Quentin, which is the big California prison, notably famous because it's where California's death row is. And although there's no death penalty in California now, there are people still on death row. And there was a transfer of prisoners from somewhere else in California into the prison. They weren't properly tested. Now about a quarter of that San Quentin prison, which has got a pretty old population, about a quarter of it, there's several hundred cases now. It's the biggest single outbreak, I believe, certainly in Northern California, maybe in the state. And of course, the thing when people think about prisons is, well, it's isolated. Yeah, it's isolated other than when they get super sick, they have to go somewhere, which is either Marin General Hospital, or they may be opening up. There's an argument about opening up Seton Medical Center, which is a medical center just south of San Francisco that was closed down. And of course, there are people who work there who are not prisoners, who come in out of the community every day. So, you know, it's the first time that this is like started touching people around me in Marin. People would kind of been not noticing this much, but it's certainly coming back. We're not yet Arizona or Houston, but, you know, it's certainly something to be watching here. So I think those are the various threads we're going. And let's start, Marcus, with you, because you've had a big week yourself. So you're sitting in front of a Health Further banner, which I know is a conference, and you've done consulting. You're also involved in founding Jumpstart Capital, which are the venture fund and innovation group. And you have put out a book this week, which is about your lifestyle. And I mentioned you're also involved in the Major League Soccer team in Nashville, which just got going and then got closed down pretty much immediately. But tell us a bit about the book.
The book basically covers the last 20 years of my life, which all takes place here in Nashville. When I moved here, I was a college dropout, had a small family, a 1-year-old, and my wife at the time was pregnant. So we had another baby on the way. I was waiting tables, living in a week-to-week motel, and you know, not really in a great position to take care of a growing family. And so it was the year 2000, so it was dot-com boom. The bust hadn't happened yet, and I thought the only thing that I would be able to do without credentials, I was seeing these high school kids riding around on skateboards getting paid $100,000 to code. I figured I could probably do that too. But this was way before Code Academy or these 18-week boot camps, you know, and it was also before Amazon killed bookstores. So you'd go to a bookstore, you'd buy a book, you'd read it, you'd go home, and you'd actually, like, you know, test all the stuff. So I did that for 8 months. I got my first job as a junior developer at a healthcare company called HealthStream that does e-learning for hospitals, mostly around nurses. Did that for a year and learned that I was not set to be in a big company, and that company only had 100 people. So that should let you know that's the biggest company I've ever worked in. And from there, just kind of continued to make my way down to the best job I ever had and the last job I ever had, which was being the 5th employee at an email marketing company called Emma in 2003. There was 5 of us. There was enough work for 10 people to do. And so there was no room for office politics, and we just all rolled up our sleeves and got into it. That was where I got equity. I learned how to build a team, watched a company go from burning cash to making its first million, then its first 10 million, grow to 50 people, grow to 100 people, all that good stuff. And I got the startup bug, left in 2007 and started my entrepreneurial journey. So that was around the time when I met my current partner, Vic, and we started Jumpstart Foundry as an accelerator, eventually evolved it into a healthcare seed stage fund as we went from being one of only 100 accelerators in the country to one of 5,000. We needed to find something to focus on. Healthcare is the strength of Nashville. So got into the venture scene that way. And, I just kind of looked back on my whole life about 5 years ago and realized there were not a ton of people who looked like me, who had overcome the adversity and who were telling that story. And I sort of wrote the book that I kind of wish I had all those years ago. And it's taken 5 years, but it's finally live. So books Create and Orchestrate. It's about entrepreneurship broadly. Just happy to be done with it. For anyone who's written a book, it's a absolute labor of love. The closest a guy can come to what women do, that's far more harrowing.
I'm going to use that with my wife as an author.
It's the closest we come.
Yes, but your one is 25 years old, Michael. So you forget the pain.
But Matthew, so are the kids.
We'll see how this works out. You'll report back in a couple of weeks, from the doghouse where you'll be. Fantastic. So Marcus, that's an amazing story. So quick plug. THCB is going to buy. He's selling signed editions, so we're going to buy 3 signed editions. The next three people who email me, I'll go back and check after 1:11 p.m. Can get it. Well, I'll buy them. So I'll send them a signed edition. All right. You can also download it on Kindle this week for just $1, I think.
Yeah, 99 cents for this week. We hit number 1 in 6 categories, most importantly entrepreneurship on Amazon. So it's been a great first week for the book. And
Fantastic. So before I let you leave this topic, you brought up something super important. And about less than a month ago, you wrote a piece on Medium called "Calling You Up," not calling you out, but calling you up, but talking about essentially, what it's like to come from a place where Nashville, talk about structural racism in the South, right? And what was going on there. So talk a bit about what you said in that piece and the reaction you've had back from the, I assume, almost all entirely white leadership of healthcare companies in Nashville.
Yeah. So, I love that I'm talking to this group that knows healthcare, because when I talk to most people about Nashville and healthcare, they're like, what? Country music, hot chicken. They don't know how powerful healthcare is in the city. Right. So, and to be honest, even though I worked at HealthStream, it was my first technology job, until we started doing the venture fund 5 years ago, I didn't know how powerful healthcare was in this town. Like, healthcare has been hiding in plain sight here. Okay. And because, we have tourism and all this other kind of stuff. But for the last 5 years, I've had the incredible privilege of, throwing big events here and being part of the healthcare fellows program that the council throws here, and becoming friends with the leaders. We talked about the Nashville Soccer Club. My primary partners in that are in the healthcare system. One of them is the CEO of LifePoint Health. So, I became friends with these people. I really started to understand this industry and the history of it. The fact that HCA was founded in 1968. And I just started to correlate some things, because I'm Black. So I'm always thinking about the history and how things might be different for me than they would be for my white counterparts. And, for me being in Nashville, when I think about 1968, I think about what happened 3 hours away from us in Memphis, Tennessee, which was the assassination of Martin Luther King. That's such an incredible hallmark in time around what was going on in this country for Black people at that time. So when I heard HCA was founded in 1968, that just started me looking, picking my heads up, stop working and start looking around. And it was pretty obvious. I'm the only Black healthcare venture capitalist in Nashville. And there's a lot of healthcare venture capitalists in Nashville. And when you look at the executive teams that lead these incredibly important corporations, they're important to the city because this is the wealth building cluster, which means that's where all the philanthropy goes, which means that's what dictates, which social services really get prioritized. But obviously, you guys know it's also really important for the country. I mean, HCA, 1 out of every 20 babies is born in an HCA hospital. And that's just one of our many incredibly powerful companies here. So when you look at the executive ranks along these companies, you start realizing, wow, no wonder Black people are dying from COVID-19 twice as often. No wonder Black women, regardless of socioeconomic status, die 2 to 3 times more often in childbirth than white women. It's because we are not at the table at the highest level. So there's no advocacy for us. And whenever people talk about Black people in healthcare, they always go right to the outcomes. But I had the unique opportunity to be in the power circles and realize, wow, these really good people who are all white don't even understand the systemic racism that underlies the system that they're working in. They want to do great work. They're in healthcare because they want to be on the right side of history, but they're in America, and all of our systems have systemic racism embedded in them. There's no escaping it. And so I wrote the post, and thank you for acknowledging the calling up, not calling out. I wasn't trying to point at these people and say, you're racist. I was trying to say, listen, the system that created the wealthiest people in Nashville and the most powerful health system in the country was born in a year where the most iconic civil rights leader that was Black was killed. There's no more clear case to differentiate the starting lines here, Right. And so try to use that as an opportunity to start a conversation and understand that when you look around and you realize, wow, I thought I got here in this position because of my talent, but maybe it's not as meritocracy based as I thought it was. Maybe there are some underlying implicit biases here. And what do we need to do to take action? We have the power. What do we need to do as a group to take action to try to, make some progress here? Yeah,
no, very well said. And I think it all comes down to a lot, especially in every society, but America has been delusional about this. Speaking as one of the two immigrants on the panel here, but there's a lot of skill in choosing who your parents are.
Right,
Michael.
Exactly.
Marcus, I wonder if I could ask you a couple of questions, because I go back to covering the industry in the early 80s. And one thing you said puzzles me, and one thing you said I'm going to slightly disagree with.
Okay.
I don't think these folks, if you look at the origin stories of the large for-profit healthcare companies, they didn't get into healthcare to do good. They got into healthcare because they've been lawyers and other kinds of things, and they got into healthcare to make money, not to do bad, not to do good, just to make money. And so I'm not sure that they were necessarily racist, not racist. They were completely focused on the green, and therefore anything else didn't even occur to them. And I remember seeing some of these folks early on when I was first naive about the industry, and that was what it was about, simply the money. And I'm not saying that folks, once they're in the healthcare culture, don't want to do good. I'm saying that just like now, Google, which got rid of its "Do No Evil" slogan, is now looking at healthcare, not necessarily because they want to do evil, but because they want to do very well economically. The thing you said that puzzled me was, if you saw bias, how you could think that your achievements are due to anything other than your own merits. I would have thought that what you would do is look around and understand that because you personally are extraordinary, obviously, that, that's why you are where you are, even more so because you're extraordinary.
Oh, I wasn't. Well, I think you're asking about me, and that wasn't what I was referring to. I was referring to the people in power.
Okay, because I wouldn't want you to put yourself down, because obviously you're really talented.
Yeah, no. I was speaking pretty quickly. What I was more saying, the people who are in power, who definitely worked very hard in their career and all these other kinds of things, when they look around and they realize everybody, is of the same race as them, they have to realize that plays a role. Now, maybe they are competing with others within their race, but they're not competing with the entire talent pool that's out there.
Absolutely.
That was the point I was making.
Yeah. Raj.
Marcus, really great to meet you. And I'm enjoying the conversation already. So I'm a bariatric surgeon, right? And I've done lots of other types of surgery. And I trained in the UK. I came over to this fair country almost 10 years ago, right? And when I was in the UK, I did a lot of work. Michael and I have a lot of colleagues in common around quality and safety and outcomes, patient care and so forth, and how technology impacts those. I wasn't aware, and it was my ignorance till I came to the US, that there was actually racial disparities in outcomes of healthcare, right? It just didn't reach the level in the UK, and, for various reasons, I don't really know whether we need to go into now, but certainly we know that there are disparities in terms of outcomes of breast cancer, in terms of outcomes of trauma, and in my own practice in terms of bariatric surgery. There's been a bunch of papers that I do the same operation, whether it's a gastric bypass or gastric sleeve, on 100 patients, and the ones that are African-American women do worse generally than the ones that are white men. And so my question on this, and this is something that I've, in the last few years reading these papers, there's a lot of work that goes to describing these disparities, right? And, retrospective, right? And I'm all about prescriptive and improving society. So I'm challenged with, can you give me I don't know if it's a framework or an approach. How can we, everything from me as a bariatric surgeon, right, an N of one, through to a health system, through to a society, start changing these disparities?
Well, I think, well, thank you, Raj. I mean, that's a great question. And I think that the conversation that we're having right now about Black Lives Matter, the reason why those three words are so incredibly important is because they started sort of around police brutality and, just the discrepancies that were happening there. But the more that we are saying it, the more we're realizing that the reason why we say it is because Black lives don't matter as much in the systems of America. And so we just generally have accepted the worst outcomes, up until now, up until we're now starting to have this conversation. We've just accepted, yeah, Black people just have worse outcomes. That's just sort of the way that it is, right? And the reason that it's the way that it is there and everywhere else, the reason why Black kids get suspended at school way more often, the reason why Black kids go to jail way more often is because we don't matter as much. So the systems, it's not even about catering to us. Like, they don't see us and they don't prioritize the trauma or the fact that we get more of all the bad and less of all the good. And they don't do that because what they're trying to do is act like slavery, all of the trauma and the ills that came from slavery have been resolved. Like American society wants nothing more than to try to say that era is done. We're good. You know what I mean? And we're not, like, we're not even close. You know what I mean? Like we literally need to go back to the Middle Passage. Like, we got to start with, like, look at how they packed my ancestors in the boats. Look at it. Just start there. You know what I mean? And look at it and feel really bad about it and think about, like, what that would be like. Now, think about what it means that my name is Marcus Whitney, but is it?
Right.
What is it? Right? And what does that mean as a child when I go to a integrated school and everybody else can be like, oh yeah, my last name comes from here and I know my ancestors and blah, 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 and they're from here and they're from there and all this other kind of stuff. And now we have DNA tests, which even 23andMe is saying, holy crap, we had bias built into our systems. It's like, it's so embedded in American society, mostly because the really sad, ugly, terrible thing about this country is that it was built on slavery. Like, that's the truth. It was built on slavery. It was built on something really terrible that happened to the indigenous people here. And those wounds, that unresolved trauma manifests in all these things. So the resolution of that is just a debt that collectively those who can pay it, which, by the way, Raj, isn't you, they have to really come to terms with the fact that if we don't get to the heart of the matter and really start to try to work at it, it's just going to keep going. Our kids are going to deal with it, and their kids are going to deal with it, and their kids are going to deal with it. Like, we should all be really tired of this. You know what I mean? And we should all realize that, like, there's just no reason for us to be in a society where one group of people who have worked for free and been abused and killed and maimed and belittled, and every time we build something up, it gets killed, and all these things. We shouldn't live in a world where we're 25% of the population, but you don't see us in 25% of the positions of power. But you see us overrepresented in death, overrepresented in being kicked out of schools, overrepresented in poverty, the country can't be great as long as that's happening. It just can't. It just can't. So I didn't give you an exact answer about outcomes in healthcare. The problem is it's so much bigger than that. It's just so much bigger.
Got it.
There's actually, so I mean, I think, and I want to focus in a bit on that and then figure out if we can swing to the sort of healthcare hospital system part of the conversation, because I know you have a lot to say about that and also about the venture part. I've seen a couple of interesting proposals lately, right? And one of them is giving a birth bond. In fact, Kim Ballard is not on this week, just wrote about that on Medium. And do you do that by saying, okay, we do that by income, or we do that by race, or we do that by, because yes, slavery and white people is terrible. There are the Native Americans who had, pretty bad. And then you can go through what happened to Asian immigrants in the West. I mean, there's a lot to be concerned about here. And there's a lot that's structural, right? So I think, how do you start solving it? But the bigger question with me is, do you try to solve the process now, or do you try to solve the process in the future, or both, right? So do you care about kids in their first year or two, or even before birth? Do you fix that problem? Because that's a huge problem. If you don't catch somebody between the age of 2, George Halverson, ex-Kaiser CEO, has written about this a whole lot and has a whole investigation about what you can use the first couple of years, 3 years. We don't have daycare. We don't even have solutions now for when they're doing, schools are going to go on lockdowns for people who can't afford a nanny or an au pair. How do you manage to deal with that? I mean, we have all those problems, right? And then more specifically around healthcare, we've had a lot of discussions about social determinants of health, and does that, should United Health Group be buying housing for people, which it is, or should they be, should Jefferson be delivering fresh farm meals? I don't know if you're doing this kind of stuff, Raj. You probably are, because you and Glasgow are smart people. But I'm just wondering is that we've got to start. We've had a lot of discussion about all the bad stuff that's gone on. The bad stuff's gone on for a long time, but we've got to start moving the conversation about what are we actually going to do. And, I'm hearing some interesting proposals. And the other problem is, and I had a long discussion with a couple of people up in the sort of libertarian front version of this yesterday, but can you do this without the federal government doing something? And if not, then really it comes a lot down to something we talked about a lot here, which is what the hell do we do after November, or is it after January? I mean, assuming we get a Democratic president, probably a Democratic, maybe a Democratic Senate, who knows, a lot going on there. So I think it's, no one can give Raj an answer about what to do tomorrow, but everyone's, as you said, Marcus, everyone's got to, wherever you are, especially if you're a big, powerful system, whatever, you've got to be looking at what you can do. And we've heard a lot of lip service. Hey, I'm wearing my Colin Kaepernick jersey. From when I'm an Niners fan, I actually got to go to that Super Bowl. But, the nature of this jersey has changed a lot over the last.
Oh, has it?
Years.
Yes.
Anyway.
So Matt, can I just jump in and
please.
almost maybe start to answer my own question? I think I fully agree with you, and I wasn't expecting like a fully baked answer, Marcus, because it's such a big problem, and I really appreciate the response you gave me. But I think, where I look at this, and there's a lot around social determinants of health. And, even when I was in London, I worked in St. Mary's Hospital, which is just near Westminster. And if you go, every subway stop you go east from Westminster, you lose 1 year of life expectancy. And I know we have that in Philadelphia, and we have that in a lot of other cities as well, right?
Manchester.
So, right. So what I think, a starting place, that's a huge area, right? So we have, I'm talking a little bit out of tone here, but we have 37,000 employees at Jefferson, right? And we need to start with them, because a significant proportion, Philadelphia, right, 45% Black, we need to start with them, and they're our own, right? And what are we doing about our employees, all the way from our CEO, our EVP and leadership, right down to the people that do food service and, looking after the parking lot, right? That is the place where we, as whether it's a health system or whether it's a corporate company or whatever, that I think pragmatically we can start listening to them, start engaging with them, and start learning from them about what is it that we're not doing right? From a leadership down and from a base up, right? And that is more than, there are a lot of tweets obviously in the last few weeks and so forth. That is more than kind of getting down in a courtyard and getting down on a knee. I get that, getting down on a knee for 8 minutes and 43 seconds is really, really important to show solidarity and engagement, but it's about actually doing, right? And I think we start with our own, and we start with our employees, people close to us within our kind of corporate family. And I haven't read or certainly heard much about that kind of scope of getting this engagement going.
Yeah.
Thank you so much, Raj. I just want to thank you for what you just said, because you did hear what I said, and you're responding with the exact right answer, right? And Matt, this is also sort of, I think, in response to what you were asking, because you were saying, is it this or is it that? And I think the answer is it's yes, right? Everybody operate within the power and authority you have to make the changes that you know need to be made. Right? You know, health, and this is the reason why I point to the health system so much. The payers have a big responsibility too, but the health systems are pillars in their community, not just because they care for the community, but they employ more people in the community than almost anybody else. So that they are just this unbelievable beating heart inside of these communities, and they have such an opportunity. This is a massive opportunity for the healthcare industry. You know, whether it's a clinical trial or it's a care coordination thing post-surgery, I don't know, but you can figure it out. That much I know. I know you can figure it out. When I look at modern medicine, the number of things we've figured out. My dad had an aneurysm in 2005, and my mom was a medical biller at Maimonides Hospital in Brooklyn, New York. My family's from Brooklyn, so my dad has an aneurysm. You know, he goes to this hospital and Maimonides, which is where my mom was working. And it just so happened that this neurosurgeon, Dr. Jeffrey Farkas, was there in residence. And this was before there was FDA approval for the procedure to take a steering needle up through the groin and drop coils in to stop an aneurysm. Okay. But he was one of the 3 people working on it. And, you know, he's told my mom, look, he's got 0% chance if I don't do something, and he's got a 25% chance if you will sign this document that says this is not FDA approved, but we're going to try to save his life. And that was 15 years ago. My dad is down here in Nashville. He had 100% recovery. Like, I know how much this industry can do. I know it is full of brave, courageous, brilliant, good people, right? But these people need to look at this really ugly problem and then own the problem. Every time this industry owns the problem, really owns it, it does something about it. And Mike, this goes to your point about the whole making money thing, right? I mean, the problem there is we don't own the fact that we are a swelling percentage of the US GDP in a way that's robbing from future generations. If we would own that problem, we'd be fixing it. Right.
The Jack Kemp solution is, I mean, if you were really the old conservatives, was it is ridiculous from an economic point of view to have this huge number of people that we discriminate against and can't contribute to the country. I mean, it makes no sense whatsoever. We have people who are smart, we have people who are capable, we should educate. It's just absurd. Now, admittedly, on the other side of the conservatives who say, hey, slavery is great because no minimum wage, and look at all the great productiveness we get out of it. But if we take away those folks for a moment, it makes no sense economically, much less morally, but no, it makes it economically for people for what we do. And I think that's where you might be going. Do you mind if I ask you a personal question, since you are in healthcare in Nashville?
Yeah.
What struck me, again, having spent a lot of time with these folks over the years, is what makes you different, and I'm curious about, is you are the equal of all those folks in terms of your economic success, your education, your articulateness. In every way, you check the boxes that your achievements in personality. It's like being a Black country western singer or a NASCAR driver, right? And so when you talk, and you said they're friends, when you talk to them about what they could do, because you're their equal, clearly, or not more so for some of them, how do they respond? How do they, because it's one thing if someone comes in who's an entertainer, like, you know, LeBron or Oprah or something, but that's not their industry. You are. So how do they respond to you when you, as a clear equal, talk to them about this?
So this conversation is 2.5 weeks old. I wrote this post 2.5 weeks ago, and it definitely caught most of them on their heels. I called my one very, very dear friend who I did not want to be on his heels about it. the day before I posted it, and I said, this is coming. You don't edit it, but I'm telling you it's coming, and I'll give it to you to read before it goes live. So the response has been varied. Some people have not said anything. Some people have reached out directly and said, you're absolutely right. It's far too long that no one said anything about it. How can I help? And then everything in between, right? And that's about what I would expect just about everywhere, right? Like we're not a monolith. We, different people have different backgrounds, are dealing with different levels of guilt. One of the things I always try to be, real about is, to your point about the one black guy in country music. It's like, this is the South. What is Tennessee making national news for? We're making national news because the governor of Tennessee cannot find the courage to remove a bust in the state capitol of one of the founders of the Ku Klux Klan. Like, these are the things that are happening in our state, right? The Mississippi just approved removing the Confederate flag from within their state flag, right? So this is the reality of this moment. And some of these people, I don't know who, they're not the ones I'm real good friends with, but some of these people are not just unaware of the systemic racism in the system that they benefited from. Some of them are a little bit more engaged in the racism, right? Okay, but I don't know those people because they wouldn't want to be friends with me. That's just sort of the way it is, right? You know what I mean? Like, that's just kind of how racism works. I'm not talking to them. I'm talking to the ones who, like, as soon as they see it, they're like, holy crap, I never saw it, but man, yeah. Or, wow, I've just been waiting for somebody to say it. Because, Mike, the one thing that was the universal sentiment back to me about this post, and it gets to the heart of what you're saying about me being the equal there, right? Is the universal sentiment was, wow, that took courage. Wow, that was so brave. And all that implies is that people are afraid. People are afraid to say this because they think they're going to lose something, right? They think somebody's going to come after them. This is real stuff, right? And the reason why I could say it, and I wrote this in the post, is because I'm an entrepreneur. Like, I don't even fully depend on the healthcare industry. If they decided to blackball me, I'll just write books and make websites. You know what I mean? Like, I don't care enough about making money from them to let them control what I say. But a lot of people, there's a lot of Black people in healthcare that have already hit that ceiling, absolutely know it's there, but it's how they pay their rent. It's how they pay their mortgage. It's how they're paying for their kids to go to school. And they know, because Black people know there's a thing called code switching, right? Like, we know that we don't benefit, or up until this moment where, like, Aunt Jemima is getting removed from, from everyone's table. But, like, up until now, for Black people to succeed, generally speaking, you had to not, it was called pulling the race card. You couldn't refer to your race or the significant additional adversities you had, because you'd get dinged for it. You get knocked for it. So many, really, really great people who probably could be CEOs of one of these companies that haven't been, because they've hit that glass ceiling, because they don't fit in or get along or whatever the thing is. They have too much to lose. So we'll see. It's an ongoing conversation. But I have high hopes, and they're not just because I have belief in these people. I've also been encouraged sufficiently, and I intend to continue to push this needle and do more than I've done in the past as well.
That's great. So I want to make sure we get Dan in here, because it's been a while since we've heard from him. Dan, you've been following, probably more than anyone, as much as anybody, the overall sort of impact of healthcare dwindling, growing as part of GDP in some of the numbers, but also just the impact of employment. And, as what Marcus referred to, is how much wealth has it made / wealth has it taken from other parts of the economy. So I don't know, there's a lot of big issues there. What's your kind of view of what you've heard so far, and where you think we are at the moment and where we're heading?
There's a point that Marcus made, I think, at the beginning here, where he was talking about thinking about healthcare, particularly in Nashville, but frankly everywhere, as an engine of wealth creation, and whether that is equally accessible to all parts of American society, or has an equal effect, or sort of benefits all parts of American society equally, which it clearly does not. And I think there's a couple of ways. We often talk about sort of health inequities, which clearly exist that are severe, but we sometimes gloss over, I think, the way healthcare as an industry, as a massive sprawling industry, contributes to and exacerbates some of these inequities that already exist at baseline. And I think it happens in a couple of key ways, which are absolutely addressable immediately as a matter of choice for those that are in healthcare. So one of those is just as an employer and wealth creator, right? You walk the halls at HIMSS, you look at the boardrooms of a lot of big hospital chains, they are not a representative group of American society. And wages in healthcare are higher than they are in the rest of the economy because the prices are through the roof in healthcare, right? So healthcare is consistently transferring wealth from other parts of the economy to insiders who profit directly from healthcare, right? And if the insiders are not representative of the broader society, then that's probably exacerbating inequality. The second way is, I would argue, there may be more, is we know that our largest, wealthiest healthcare institutions do not offer their services on an equal basis to all comers. So at the end of the day, we know that HCA and LifePoint, these are extremely well-run businesses, right? You have to have a lot of respect for the way they run a tight ship. But it is true of the for-profit chains. It is true of many of the large academic medical centers, whether it's Stanford, the University of California, it's probably true of Jefferson, I haven't seen the numbers. They are not available in many cases to Medicaid patients. And Medicaid patients are disproportionately brown and black. And that's rooted fundamentally in a price discrimination strategy that, frankly, physicians, particularly in specialist areas, and hospitals have chosen to run for decades. So you have to step back for a minute and say, if you're putting out statements saying that Black Lives Matter, if Black Lives Matter, then you should be treating Medicaid patients at the same incidence that they need care in the community that you serve. You can't be seeking out privately insured patients that are disproportionately white. But in the most literal sense, if you're putting out these statements, put your money where your mouth is. And I think that's true certainly in who you hire and who you put on the board, who you promote to executive positions. It's also true in who you decide to serve. And these are institutions that have the resources to make that choice. They might be a little bit less profitable, not dramatically. They can definitely afford to do it, but they choose not to. And that is an active choice that I think we have to recognize as contributing to both health inequities and economic inequities.
So I want to ask Raj about this and then open it up, because this is, critical stuff. But as you may or may not, most people who listen to this know that I've been pushing for a long time that we need to change the basis of what we're doing, get away from large provider system-based healthcare and move to a sort of more community-based approach using technology. I know Raj is a fan of that, but he's in a system which knows more about that as its CEO than many others. But nonetheless, it's been really tough. What have we got now, right, is that right now, everyone's, the evil person who's forgotten to turn off their phone. I'm always being told by Zoya to turn my phone off, and I never damn well do. What we've got now is everybody in healthcare scrambling to get back to where they were, right? And where were they? They were more elective, more visits. The telemedicine visits are going down. Raj, you've talked about this a couple of weeks. The in-person visits are going back up because you can add more stuff on and make more money at it. People are trying to get back to normalcy. Raj, Dan, you both looked at it. I mean, everyone in this call's looked at this a lot. But is there a significant attempt for the big players here to take some of those reserves and restructure themselves? I mean, a lot of them are getting CARES Fund. I put together a little spreadsheet, which I'll share again, of a tiny spreadsheet I'm trying to put together of who's took what in CARES Fund or early Medicare Fund and who's got what in reserves, from some of these bigger systems like the Mayos and the Ascensions who are sitting on more than $10 billion in cash. When are they going to start using this money to change what they're doing? And are they doing it? I mean, I see the Mayo has started talking about working medically home to do hospital at home stuff, and maybe that's part of the process. But again, we are not in a community-centric, at-home-centric, monitoring, caring, what I call the continuous clinic situation anywhere close. I haven't heard as much about getting there as I'd like to hear. So Raj, Dan, you want to care on commenting whether I'm being just ridiculously optimistic?
So the first thing I'd say is this is really hard stuff, right? These systems, whether it's policy, regulation, business models, right? It's really, really hard. And lots of very, very smart people have been working on this for 50 years plus, right? And the other thing is, Zeke Emanuel just had his book published of, the best healthcare system or whatever in the world. And he said it was Netherlands, right? I mean, I don't know why it's Netherlands, right?
Alan Enhoven, my former professor at Stanford, is why it's Netherlands, because he's a profit ignored in his own country and he set up his competitive non-profit, multiple Kaisers. Yeah. Anyway, well,
I mean,
that's why.
I'm pragmatic. There is no best healthcare system because we're smart enough. If it was, we'd just take what the Netherlands have and put it here, or whatever. We'll just push it through. There is just so many variables, right? So that's the first thing to say. The second thing to say is you're absolutely right. Jefferson and a bunch of other health systems didn't just suddenly wake up on March 16th or whenever it was, March 13th of this year and say, oh, shoot, we better do telemedicine and remote monitoring, right? This is not new. We've been, through my CEO and through the work that I do at Jefferson, we've been working on this for at least 5 years. And it's slow, it's purposeful, we make mistakes, and it's hard, right? So that's the second thing to say. And then the third thing to say, and it kind of goes back to my earlier thing I said right at the beginning, at the top of the conversation, is that I was thinking about this, the whole kind of telemedicine, and how 6 weeks ago, all of my clinic visits were telemedicine. And now, I have a clinic of 16 people on Monday, and only one is telemedicine, right? That's what it was 6 months ago, a year ago. I have the one person. Even though the patients are getting the choice, they're saying, hey, look, you can see Dr. Aggarwal by telemedicine. No, I'd like to come in. And we discussed this a few weeks ago on one of these calls as well. And so how do we not lose this opportunity? And the phrase I'd say is it's a one-hit wonder, right? I don't want telemedicine and remote monitoring to be kind of the one-hit wonder, Vanilla Ice or whatever else, whatever other example you want to use on this, right? And so we really need to be honest about this, right? And that's where I was saying, is it real in terms of Teladoc's valuation right now? And not let the stock market drive this, which is what I think is happening right now. There needs to be the reality on the ground. Look, this is what I'm seeing. I'm a frontline provider. This is what the health system is seeing. We're, many hundreds of millions of dollars in the hole right now. And what do? We go back to what we know, because that's the way not Jefferson Health System. That's the way the system of health is run, right? It's fee for service, and it's heads in beds, and that's what we know to get back to. So there's a lot of chatter around this, but the reality is this is going to take time, and we've already been working on it for 5+, maybe 10 years, and it's going to take many, many more years. And this is going to be COVID, and telemedicine and remote monitoring is a propagator, but it's not the defining moment. It's not the transformation of healthcare. And I think we're pretty dumb if we think it is just going to flick the switch, and that's going to transform it.
So Dan, you said a lot about, I'll come to you in a second, Michael, but Dan, you said a lot there about the extraction, and Dave Chase and others have talked a lot about this, the extraction of, and Brian Klepper, who we mentioned earlier, the extraction of wealth from the rest of the economy to healthcare. Obviously, how that's got divided up is a big question, but I mean, you can argue that there'd be the real wage in this country would be much, much higher if healthcare only grown at inflation rather than grown at 3 times inflation, what it's done over the last 20, 30 years. So give me, what do you think you're seeing being done? And if nothing, what would you like to be done to think about how to change that?
I'd say one positive point, one negative point, and one maybe to do for all of us. The positive point, I think, at least at the generational level, my perception at least is, which may be skewed in various ways, but my perception is that younger physicians, younger nurse practitioners, younger nursing leaders, informaticians, that sort of whole stratum of earlier career clinicians see this. They see this problem. It's not what attracted them to healthcare, and they would like to see change. And you start to see that in the votes, even at the AMA, right? Where you're seeing younger physicians stand up and say, you know what? Maybe we should look at something like single payer. Maybe we should support it, because that would take the price discrimination profit opportunity off the table. But frankly, we're all doing pretty well, and maybe we could focus on other things that are more interesting for us intellectually, scientifically, clinically, et cetera. So I think that's an encouraging thing, and I see that both in their interest in delivering care in different ways, but also their interest in sort of ratcheting back the fixation on sort of on some of the pricing games that go on. That's the positive point. The negative point, I think, is, to be honest, I don't see a lot of hospitals or health systems, which is sort of this $1 trillion slice of the pie, making serious switches. What I see is they've got innovation groups and they're certainly trying to layer this on, but whenever it comes down to prioritization, it's fee for service, it's heads and beds, it's the usual, it's the amount of money that goes into the back office billing and coding systems to extract an extra percentage point or two on next year's claims dwarfs the investment typically that goes into actually delivering care in cheaper, more accessible, more convenient ways. And I think it's very tough for them to get away from. So where do we go from here? My argument for a long time has been, you really can't expect people to act irrationally. You just can't. The gravitational pull of this is too strong. If we want to affect change, we have to start ratcheting down the prices that they are allowed to charge, particularly for privately insured patients under fee for service. That needs to no longer go up. What we need to shift to is a place where your only revenue growth opportunity is to do something new, different, to expand access, to deliver care in a different, more efficient way at a lower price point, et cetera. Do things that expand productivity. Then you would see incentives shift and you would see behavior shift, I suspect. But that ultimately will have to be politically driven. It can happen at the state level or the federal level, but that's the only power that exceeds $1 trillion hospital system at this point.
Michael.
I want to reinforce what Dan and Raj both said, because I think what we're all talking about is how do you change the culture of healthcare, right? And I used to make talks, give talks where I said, grab them by their wallets and their hearts and minds will follow. And that's really what it is, right? And if it makes you feel any better, Marcus, my focus is on safety, and hospitals are pretty good at killing middle-class white people from hospital infections and medical errors.
Oh, equality under the cultural law.
And not only that, you can go to a big name institution with a lot of famous people, and you can have a graduate degree and trust them and still have your kid killed, right? And I've looked at this, and I've been writing and speaking about this issue for over 20 years. And when I talk to friends to see whether I'm too cynical because I'm not keeping up, I said, do you think as many as 5% of all hospitals are trying to be high reliability organizations? High reliability, no harm. That'd be 250 hospitals out of 5,000. And almost unanimously, people don't even hesitate. They say, no way, right? And that's 20 years after terror is human. And the kinds of things that Dan talked about. So I think the culture traces back, and I think about this, and Raj, you would know this better than I would. I personally was surprised by the hierarchical nature of medicine and how whether you were a chief resident at Harvard in the 1970s is something that's important today, right? And where you train and all. And the hospital industry, despite everything, this goes into what Dan talked about, fee for service, is still the doctor's workshop, right? And so it's not that people don't care about racism or safety or 6 other things. It's at the end of the day, the foundation underneath is people come in to get fixed. We have the people who fix them and we keep them happy, and they fix them and we bill for it, right? And so it's how do you get their attention and how do you change the culture? And I agree with Dan about the younger folks, but at the same time, if you take a look, when they go into the system, their values get changed often over time because like Marcus said about the Black executives, right? Don't make too many waves. And so what you're hearing is how do we change the culture so that we look at something other than the doctor's workshop? And it's absolutely value and patient measures. I mean, I've done a lot of stuff looking at patient satisfaction measures and how if you look at minorities, it's different. And we don't do that. We don't look at Black patients' distrust of the system. We don't look at a lot of other issues at different ethnicities, different ways. So once we start to pay people where you have to pay attention to our differences and to things beyond, processing folks, then there'll be some change. But it's really tough, as you've heard, because good people are in a culture that's doctor's workshop.
Raj,
so, Michael, just really quickly, I think we are talking about culture, but I think it's also talking about how we do care, which is very transactional. So I'm a surgeon. I'm going to do a gastric bypass on you. It doesn't work. You're now going to go and go to GI or go to nutrition and so forth. If we really want to develop a whole person care model, right? And that's not just about all the different organs, your kidneys and your heart. It's really about the whole person. It's about the social determinants. It's about your genetic determinants. It's about where you live. It's about what you want, what your thoughts, values, beliefs are, all of that stuff. And if we can have a healthcare system that really prioritizes that, then I think we can really start to make a dent in what we've been talking about in the last 45 minutes.
Amen. Marcus.
I know we've been talking about hard stuff, but I'm incredibly inspired by this conversation. What a brilliant gang, and I need to be tuning into this show more often. That's my.
Of course, that's the way we build listeners. We get them on one at a time. I always
look,
said, I recruited people to come to the Health 2.0 conference. You probably the same with Health Third. Every time you met, hey, want to come to a conference?
Yeah, that's right.
Eventually, you build the movement that way. And I think these kinds of conversations are moving. Before we go, I have to change the topic. But you and Raj are both making deals, and what do you see on the venture side that you're interested? Just give us a two-word topic.
I mean, look, it's the last 90 to 120 days have been a complete roller coaster. Raj, as you said, it was okay. It's all telemedicine. Nope, it's all going back to the way that it was. So, there's nothing in particular that's piquing our interest now. And if the industry is stuck based on the incentive models, the venture industry is definitely stuck in the incentive models, right? So, all too often, some of the most exciting stuff that we get to invest in is going to be consumer stuff that's not reimbursement based. You know what I mean? Because it actually has the chance of changing somebody's behavior or something like that, keeping them out of a hospital. Quite frankly, the stuff that we do in the hospital, lowering costs. I mean, it is what it is.
Raj, are you looking at this from your other side of your job differently?
Yeah, I don't know if it's going to happen in the next week or so, but it kind of goes back to something.
We're not on that one yet. You're allowed to forecast out. If you're a venture investor, you don't have to make a return of the week. That's a Teladoc day trader.
Okay, so what I would say on the venture side that I would be looking out for is how can we best support our employees? They've gone through hell and back for the last 3 months, right? There's got to be stuff out there that we're very much focused on our patients and our workforce, whether they're digital technologies, monitoring, other things, really to enable our employees to, see the joy in life again, right?
Fantastic. All right, so we're at very close to our wrapping time, and as is traditional on the THCB Gang, we go around and ask everyone their forecast. We asked you what you were excited about in the last week. We asked you your forecast for the next week or weeks. Hopefully some good barbecue or a good weekend off with some measure of social distancing rather than a country music concert or craziness on the beaches of the beaches of Southend in the UK or the city centre of Liverpool, where Raj, you and your fellow Liverpool fans were out congregating after they won the league the other
I was born in Southend.
You were born in Southend? Southend and Bournemouth crowd. I didn't know that. How do you become a Liverpool fan? It doesn't make any sense.
I'm an Arsenal fan.
I thought you were a Liverpool fan.
No.
Oh, look at that.
At
least we're here to sort out the big issues on the team. All right. Okay, so Michael, your forecast for the next week or weeks.
We are going to teeter between worrying about healthcare issues like access, will the ACA be overturned, and worrying about whether we're all going to die again from COVID.
Dan.
Yeah, I think we're all going to be watching sort of with a hawk's eye where the COVID curves go and what effect that has on healthcare institutions. Whatever criticism we have there, obviously it's absolutely essential infrastructure. And there's a lot of stress in Houston and elsewhere.
Raj.
I'm going to be watching the beaches of South Jersey and just hopefully not seeing thousands and 10,000s of people going there. We're certainly staying in Philadelphia. We ain't venturing out.
Okay. Marcus, your guess for the next couple of weeks. What are you watching?
Well, Nashville's mayor just rolled us back one phase. So our bars are closed again. So I think what I'm going to be watching is just the sentiment of society. People really seem to be fed up with the social distancing, the whole mask, non-mask thing. And I'm going to be really taking an eye to how is our society, even in this city, going to respond to the rollback. And, you know, are we going to see outbreaks of just the social fabric sort of falling apart? That's the thing I'm most worried about.
Yeah, and I've got to say that my full goes is I'm looking at that as it changes. You know, are we going to get people? We're coming up to two really important events, right? One is the sort of summer vacation, go to the beach phase. The other one is the reopening of schools, which is absolutely critical for most people who have schools, dual income families, and that's been education, especially elementary through high school, has been a dramatic impact, especially on people who you know, can't afford either childcare or can't access it and have to go out to their jobs and can't sit. It's bad enough that you're at home doing Zoom. You've heard my kids screaming in the background during this, but it's terrible for people who have to go out and do essential services, because what do you do if your kids can't go to school? And we're going to have to look at how that happens across the nation. That's going to have lots of impacts on us now and in the future. So that's one thing I'm looking at carefully. And the other thing I think has got to start coming out, we're kind of heading towards what would normally be convention season, right? In an election. And at some point, you know, it's okay to keep putting out tweets about Trump's the lunatic, or, you know, don't drink your Lysol, or whatever Biden's been saying to this point. At some point, we've got to start thinking about, if there is going to be the quote unquote Democratic sweep we're hearing about, and Trump being way behind in the polls and the swing states, et cetera, et cetera. If that's the case, at some point there is going to be the renewed battle. You've seen it in not in Tennessee, but in Kentucky this week and in New York, between the kind of more AOC Bernie side of the party wanting to talk about changing the way that they do healthcare and everything else, and the kind of Joe Biden steady hand on the tiller. Let's get America back to the sort of the more mainstream kind of Obama Clinton era that we saw before. And that, given all the stuff we talked about, what's going on in the streets now, but also the issues around healthcare, not just healthcare, right? But also, I like to keep talking about energy and transportation and climate change and housing and, you know, income inequality and redlining and 8 million different things that you can imagine all need to be changed relatively rapidly if we're going to fix some of the problems we talked about today. I think you're going to start to see that really bubbling up in the Democratic Party in the next few months, because we know, you know, fingers crossed in my case being a good Democrat, but that we probably have a small chance in January through June of next year to get some of this stuff done. And it's going to be, you know, an extremely crucial time, because we've been sitting, not doing anything, essentially, on this whole COVID recession thing since it started, because we have a completely dysfunctional executive branch. So that to me is where I think the big change is going to come. And I think you'll hear rumblings about that starting in the next couple of weeks. All right, well, that's my rant over. And I have come to the end of the THCB Gang. That was just a fascinating conversation. I really enjoyed that. Next week, we will be back, and I won't be here, but Zoya Khan will be here, and hopefully we can have an all-female panel, because there are way too many men on this panel. Zoya, maybe you have better luck recruiting some female participants than I had this week. But I really want to thank my guests, Rajesh Aggarwal from Jefferson, Michael Millenson here in Chicago, quality patient safety expert. And I want to point out, plug for his book, Demanding Medical Excellence. Fantastic book, even if it is